And when I was taking my oral exams, my oral examiner said, "You would refer this to another gynecologist?" And I said, "No, I would refer it to a gynecologist." They said, "Are you saying gyne-oncologist or gynecologist?" I guess my Midwest accent and fast talking pace told them I was saying gynecologist, but I will always now say gynecology oncologist. Disco Queen. You've seen Chemo Bear, Chemo Kid, Chemo Man, all kinds of chemo people, but you've never seen the Chemo Disco Queen. It's time for her to rule. Up on her head is her crown of disco, which shows you the nitrogen mustard's neurotoxicity. Coming down, you can see that she has C earrings on and C pockets on her coat that are pink. That's going to be your ototoxic and nephrotoxic effects of cisplatin and carboplatins. On her chest, she's going to have the D and the B of doxorubicin and bleomycin, which is cardiotoxicity and pulmonary fibrosis. The CP on her belt is to remind you of cyclophosphamide, which has both hemorrhagic cystitis and ovarian failure. That's why we've drawn it that way, to kind of remind you there's two things you need to remember about it. Methotrexate and 5-FU are hanging out on her bell-bottom stylish pants to remind you of the long bones and myelosuppression of them. Her really cool elevator platform shoes that are blue and her blue peace sign up in her hand are to remind you of the peripheral neuropathy of vinca alkaloids. We'll talk about this in the cell cycle too to make sure you understand these, but everything on this page except for the blue vinca alkaloids is S phase. So everything else is S phase for the cell cycle. Page 61, we're going to look at the cell cycle now. So I always think of cisplatin and carboplatin like platinum card members or platinum members in a club, and they can go wherever they want. No blackout dates for them. They can travel when they want. They can go where they want. So they're non-cell cycle specific. When it comes to the M phase, which is mitosis, I just think of it as the money phase. So that's why it's in green for me. Because when you get your first paychecks for taxes, when you become an attending and see those taxes that are taken out, you're going to need some alkaloids to settle down your heartburn. So Taxols, money phase, vinca alkaloids. G0, nothing metabolically is happening there, so nothing's important there as far as the effect on the cell cycle. G1 is your hormonal agents. So tamoxifen and megestrol are the most active here in this cell cycle phase. Now, there is some G1 activity of the anti-tumor antibiotics like doxorubicin and bleomycin, but they're mostly in the S phase, and that's why I remember them there. These are the A groups: alkylating, antimetabolites, and anti-tumor antibiotics. So those are all going to be found in the S phase. G2 is only lent to the non-specifics. Otherwise, there's nothing else that's going to be in that area. Histology of ovarian cancer. Now, type 1s and type 2s is cell behavior and cell type. Type 1s come from the fallopian ovarian surface epithelium. This is where you'll find BRCA1 correlation. This is extremely high-grade serous carcinoma. This is going to be the big one that you see all the time. Most common subtype of ovarian cancer, 70 to 74%. Type 2 comes from the endometrium. So these individuals usually have correlation with endometriosis, and this can be clear cell, which is not the same as vaginal, and endometrioid carcinoma. Mucinous carcinoma usually has an appendiceal origin, and it has a marker of CEA, which is different from all the others. So it's a good thing to remember, but it's rare. Non-epithelial ovarian cancers are in the orange colors at the bottom. This is going to be your extremely rare sex cord stromals, which is your granulosa, thecoma, fibroma, and Sertoli latex and Sertolis. A little bit more common, but still extremely rare, is the germ cells, 5 to 7%. This is your deep CT mnemonic, which is dysgerminoma, endodermal sinus or yolk sac, embryonal, polyembryonal, choriocarcinoma, and teratoma, which we cover a good amount of all of these pathologies during the exams for you. That is high yield. On the right side of the page, you can see that we have the different types a little bit more broken down for you. Here's some things that I would want you to know. Clear cell is extremely aggressive. So I just think of somebody washing a window that they want clear and they're just scrubbing aggressively on it. And it's poorly differentiated because they can't see anymore what's bad and what's good. So aggressive, poorly differentiated, clear cell. Mucinous. This is going to be rare, but again, it's not CA125 like all of the others. This is going to be CEA as a marker, and we told you it's usually related to the appendix And this is a gyne-indicated reason for appendectomy. Endometrioid, I always think of this word sounding like a droid or a little robot. It's well differentiated because it's very organized like a robot, has a high survival rate because robots live probably longer than us. And it also has a BRCA1 correlation. This is the second most common ovarian neoplasm. Serous, we've been talking about. Again, the high-grade form is related to BRCA1 with low p53 and also a CA125 marker. And again, it's the most common subtype of ovarian cancer. Don't forget about these ghost ones down here. That's transitional. These are extremely rare, but they are things you should know exist. Brenner tumors and transitional cell carcinomas. Head over to page 67, and that's going to be actual cancer processes of the uterine body. This is going to be endometrial stromal sarcoma and things like leiomyosarcomas. And leiomyosarcomas, you should realize, are age 55 to 65. That's usually when they're found. These are unfortunately found postoperatively, and they are related to hormone exposure and pathologies that go along with increased hormone exposure. Surgical treatment with chemoradiation is usually done, but this is extremely aggressive when it's found usually and has high recurrence, and it usually ends in the outcome of death. So extremely aggressive leiomyosarcoma. Up at the top is carcinosarcoma. Now you may know this or did know this as malignant mixed Müllerian tumors or MMMT. Again, this is 55 to 65, but these are greatly known for their aggressive metastasis, which is going to be a lymphatic spread. So lymphadenectomy is commonly done with carcinosarcoma. Now we started calling it carcinosarcoma because that's really what it is. It has two tissue lines in it. So the tail of two tumors. The carcinoma is the epithelial component, where the sarcoma is the mesenchymal connective tissue component. Carcinoma is the epithelial side, and that's aggressive. It's an aggression is based on my side, which is the carcinoma side. So I think of Pac-Man being aggressive like the sea and eating up all those little ghosts. Page 68 is the hereditary cancer syndromes. This is going to be things like BRCA, BRCA, Lynch, Lied-Fermanti, Cowden, and Peutz-Jeghers are the most common to be talked about. BRCA is BRCA1 and BRCA2. You know these. Now, the black dots are just in the rows that they correlate with. They have nothing to do with the columns. They're just in the rows that they correlate with. But there are also the dots that are showing you which cancer types are related to that row cancer as well. So let's look and talk about some of the important facts here. First and foremost, let's skip past BRCA1 and 2. You know those for sure. But I want you to notice there's only one that does not have a breast component. That's going to be Lynch syndrome. Lynch is an ovarian, endometrial, and colon cancer, and it does not have a breast component. This is going to be microsatellite instability, which is reminding you a little bit of MSH2 and MLH1, and it's a mismatch repair gene issue. The other cancers that are in the far right column sometimes pop up, and they're part of some of our stories here that we're going to help you remember these with, but not always super high yield. Lied-Fermanti sounds like Fraulein in German, and we just think of a German wet nurse, and it's a breast cancer. She's 53 years old, and she's still acting like a wet nurse. And this Fraulein is incredibly smart. So she has a sharp brain, and she has strong German bones and tissue, sarcoma, and bone cancers. Cowden syndrome, think of cows. You have 10 cows out in the pasture. Those cows have udders, so there's breast cancer. There's endometrial cancer. You can think of the endometrial as the grass out in the pasture. And colon, again, sounds a little bit like cow. So it's also related. Thyroid can be remembered by thinking of the cowbells hanging around those cows' necks. And benign hamartomas are, again, things that hang down, so the udders on the cow. Peutz-Jeghers sounds like some kind of cartoon or video game shoot 'em up kind of person. So Peutz-Jeghers looks like this Arnold Schwarzenegger character in my head, and he's using his STK-11, which sounds like some kind of dangerous thing. And he's Peutz-Jeghers will come shoot you up with your STK-11. That's my best impression. I won't do it again, promise. But I think of Arnold Schwarzenegger, who has those big pecs, so he has breasts. Ovarian, because ovaries are always braver than their counterparts. And then colon, because it looks like colonel, C-O-L, in the military. So you can remember colon cancer is also involved. I'll help you out with one more thing. Everything on this table is autosomal dominant. Whether a lot of PAP questions pop up or not, usually this is pretty low yield for PAP stuff for the reason that there's an app for that. And there's also a lot of changes that happen frequently. But there are some things that will always stand true as very important to know in the glandular side of things. In the glandular side of things, we have AGC. AGC looks like the word age. So Granny's telling you, pay attention because age matters when it comes to AGC. AGC is always going to get a colposcopy with ECC. Now, whether they get an EBMB or not is based on their age, if they're greater than 35 years old. But if they're less than 35 years old, then pretty much they look like a patient with PCOS, unexplained vaginal bleeding, menorrhagia, and chronic anovulation. So remember that EMB has a couple of factors onto whether it's going to be done or not. Concerns from AGC, the reason it's a big deal is because it either is CIN or CIN again after, endometrial adenocarcinoma or cervical adenocarcinoma. So we don't want to mess around with Granny, and we're going to pay attention to the age. AIS, there's a little ladybug there with spots to remind you that AIS has skip lesions. It's all over the place. AIS, you're going to do a colposcopy with ECC with or without an EMB. Again, those EMB requirements match pretty similar to AGC, so I would know those. As you can see, a lot of these things also turn into higher level pathology, and you want to watch carefully for them. Now, this is the one time that cold knife cone, if you're going to be doing that straight off from AIS, is going to be the preferred surgery to do. This is because the margins remain available for pathology without damage from that thermal energy. So cold knife cone in any other situation over LEEP is not going to be talked about. But this is the one time that cold knife cone is preferred over LEEP. Let's head into REI. All right, now if you know cholesterol synthesis really well, you're allowed to fast forward or take a nap because I don't want to show you my way and mess it up if you already know it. If you're comfortable with that waterfall model that everybody looks at all through residency and is in most of the REI books, go with it, enjoy it. But if you've had trouble with it or it's not clicking in for you like it never did for me, I literally flipped it on its side and turned it upside down, and it made everything clear to me. So let me walk you through my cholesterol synthesis pathway and see if I can help you out if you haven't gotten it before. First of all, there's 4 quadrants once you get past the cholesterol side chain cleavage enzyme. That's the first part and the actual entry point into the cholesterol synthesis for hormones. The 4 quadrants are going to be quadrant 1, progestogens, quadrant 2, mineralocorticoids, quadrant 3, androgens, and quadrant 4, estrogens. I'm going to talk about them in that order, and that's why I'm letting you know the numbers. That first quadrant, progestogens, is the entry point into this synthesis hormone pathway. That's going to be the yellow area. We come in and we form first pregnenolone. That's the first thing that's common to all of these other endpoints. So it's not cholesterol, it's technically pregnenolone because that's what's in the cholesterol synthesis pathway. Pregnenolone is one of the progestogens. So all you need to know is it's either going to be called progesterone or it's going to be a pregnenolone. That's all I need you to know, those 2 words, and you know it's progestogen. Now, when you're going from your progestogen, you're going through 21-hydroxylase over to zone 2, the mineralocorticoids. Now, I don't think of 18 as adulthood. I think of 21. You start paying taxes, you have a regular job by then. So let's consider 21 as true adulthood. So that's when the stress of life really happens, right? So once you get past there, stress city. And hey, look, a lot of these are stress hormones, right? Your mineralocorticoids. So it makes sense. Now, if you're not going to get past 21, I'm not going to knock you just back to 18. I'm going to knock you all the way back to 17. So you got to do it all over again. So we'll talk about the 17s in a second, but just remember, if you get knocked back from 21, you're going all the way back down to 17. But let's go into that stressful life after 21 and talk about our mineralocorticoids. Now, these are always going to have just a couple of names. Again, corticosterone or cortisol, and they're related to each other. If you're ending up with something with just one name, that's usually going to be the derivative of the previous. So corticosterone and cortisol are our 2 main things that we're going to form here. Corticosterone can turn into aldosterone. So aldosterone is another endpoint, and that goes through aldosterone synthase. So it's kind of an easy one to remember what's going to come from that. Now, we talked about 21-hydroxylase, and that's going to be the #1 cause of congenital adrenal hyperplasia. Now there's two other possible causes, and that's going to be the second most common, 11 beta hydroxylase, and the third most common, which helps us out because it has a 3 in it, 3 beta hydroxysteroid dehydrogenase. So now that we know those 3 types, we're going to pay attention to the number 1 type, which is that 21 hydroxylase. So remember earlier, I told you if you're not surviving that stress of adulthood, you're not even going to get there. I'm just going to knock you back to 17. We're going to skip past 18 and just go right back to 17. If you're talking about 17s, you're talking about the conversion of progesterones down to androgens. So we're going from quadrant 1 down to quadrant 2. So those 17s again are moving you through the progestogens and down to the androgens. Kind of makes sense because you start out as alpha and you end up as beta. So the beginning is alpha, the next one is beta. If it's telling you all of those ages in between 17 and 21, that's going to be the one that's in the middle. So again, you start with an alpha, you end with a beta. If it's got more numbers to it, that's going to be the one in the middle. That's going to take us down to quadrant 3 in the purple, the androgens. Now in the androgens, there's going to be dihydroepiandrosterone, androstenedione, androstenediol, and testosterone. And then the important one here is 5-alpha reductase as the first enzyme we're going to pay attention to. 5-alpha reductase is something we work with medications and pathologies. And what it forms is takes testosterone to the most powerful form of androgens, which is dihydrotestosterone. It's like many, many, many times stronger than all the rest. So I always say that DHT is the strongest. I just remember that. And the others are a tad below because that's going to be testosterone, androstenedione, and dihydroepiandrosterone. So they're just a tad bit less, and this is strongest to weakest in that order. So now you can remember your androgens and their strengths. Now, if we don't go through 5-alpha reductase, we're not going to become that DHT. But the next place we can go is head through aromatase. Now, I'm going to tell you that I remember aromatase because I think of my mother. My mother has estrogens and she loves to cook things, and she always had wonderful, lovely baking smells in the house. So I think of that wonderful aroma of my mom making baked goods. Now you can think of my mother on your exam and you can pass and you can thank her later. However, moving out of that aromatase takes us to quadrant 4, which is our estrogens. Now estrone is E1 and estradiol is E2. Now there is an E4 and that's a natural form, but we'll save that for a later time. E1 is estrone and E2 is estradiol. E1 is when you're all alone and you're sitting on your rocker on the front porch rocking because now you're a granny. So postmenopause is the very weak estrogen of estrone. So the estrogen of menopause and post is E1. Estradiol has di in it, which is 2, and it takes 2 to tango. Well, at least a sperm and an egg to reproduce, right? So that's your reproductive estrogens, estradiol, which is the strongest of the estrogens here. If you go through the liver and the placenta in a pregnancy, you're going to end up with estriol. Estriol is E3. Tri-3, also trimesters, which reminds you of pregnancy. So that's going to help you remember your different estrogens and the order that they come in, because it's E1 and E2, and then E3. All right, if you were taking a nap, or if you just skip past, you'll never know. But this is the cholesterol synthesis pathway and how I teach it. You can come back to us now because we're done teaching it, and we'll head on from here. But hopefully for those that needed it, it helped. Ovarian hyperstimulation syndrome is a result of IVF procedures giving gonadotropes. Gonadotropes create multiple follicles, which are taken up by oocyte collection when they're ready. Now, we're going to put off a ton of estradiol. That's why estradiol is an important monitoring when you're doing follicle stimulation with gonadotropes. Now, when we take those follicles away, we actually leave multiple corpus lutea left behind. With those being left behind, they start putting off things like VEGF, IL-6, and IL-8. These are actually the most important part of ovarian hyperstimulation syndrome because this causes the capillary leakage that leads to all of the pathological process like tissue edema, hypovolemia, and hemoconcentration, which is one of the scarier parts because it causes thromboembolism. Now, treatment and management is there for you, and all you're doing is treating the things that are coming from that capillary leakage. But again, I would remember that's VEGF, IL-6, and IL-8. Puberty. We go with TAGM. TAGM is the best because it actually gives you the progression and how it happens, and it also points out adrenarche. So when you're looking at TAGM, the breakdown is this. Puberty initiation is the function of becoming sensitive to estrogen. You're a little oversensitive to it in the very, very beginning. So here's your gonadostat sitting there, and there's like one little estrogen. And it's like, estrogen. And it freaks out, and it's brake pedal, brake pedal, brake pedal. Not doing anything. I'm terrified. Then there's like 2 or 3 estrogens as we continue to mature and the ovaries start putting off more hormone. And they're like, I'm getting used to you, but I'm still not okay with it. Brake pedal, brake pedal, brake pedal. At some point, it gets desensitized to the fact that estrogen's there, and it lets off the brake pedal and only goes back on when it's a super high amount, which is the normal shutoff for the HPO axis. So now we've got puberty going. This is also when hormonal adrenarche is happening. Hormonal adrenarche is part of the process of that puberty initiation, and we know that it can actually happen independently of the rest of this HPG axis. We know that because individuals who don't go through this puberty in a normal fashion still have adrenarche, like gonadal dysgenesis. So let's start down the average things that are happening in age for the different parts of puberty. The first one up is at 10.5 years, and that's thelarche, or the breast bud. This is technically the onset of puberty. Adrenarche is the next one, and that's going to be onset of pubic hair growth, is the most notable sign. And then at 11.4, that takes us to the growth spurt. This is the maximum growth spurt of puberty. There is a little one that happens just before puberty initiation, but this is the maximum one here at 11.4 average years of age. The next part is menarche. Menarche's at about 12.8 years of age, and that's the average. And positive feedback starts occurring with estradiol and luteinizing hormone, which is going to stimulate more ovulatory cycles. And that's going to get better and better at doing that. And that's going to bring on the cycling that patient's going to experience for the rest of their life. Now, it gets a little hard to do it in the beginning because it doesn't know exactly how to do it. And that's why things can be irregular or heavier just in the beginning, because it's kind of getting a hold of those hormones and figuring out how to do it. Let's look at the ages and see if we can figure out an easy way to remember them. I just need you to remember 10.5. Remember 10.5, that's it. So 10.5 plus 0.5 gets us to 11. 11 plus 0.5 gets us to about 11.5 or 11.4. Then if I add plus 1, that gets us to 12.5 or a little higher, 12.8. So 10.5, add the 0.5, and then 0.5 again, and then just add 1 onto that, and that gives you the end. 82 is polycystic ovarian syndrome. We cover this quite a bit in the exams, but I just want to make sure you remember you have to have these in your differential to technically diagnose PCOS and rule them out. It doesn't have to be with labs. You can do this with clinical findings and examination and history. Rotterdam criteria, you just need 2 to diagnose: ovulatory dysfunction and evidence of androgen excess. Polycystic ovaries don't always show in those individuals with PCOS diagnosis. And we also have individuals with polycystic ovary appearance on ultrasound, but they don't have polycystic ovarian syndrome. Endometrial cancer is an increased risk with chronic anovulation, but it's with obesity that really increases the risk, and that's what's going on here. Now, individuals with polycystic ovarian syndrome do not have to be obese, and they do not have to be overweight. I have very thin patients that have polycystic ovarian syndrome. Now, insulin resistance is not part of the diagnosis. It's something they're at risk for. They have a 10-fold increased risk of type 2 diabetes mellitus after having the diagnosis of polycystic ovarian syndrome. And we know that the first-line treatment for that is diet and exercise. I know what we do in the real world, but the first line is diet and exercise. Don't you dare answer with a medication. Metformin is reserved for failed lifestyle, again, because first line is lifestyle modifications, and or someone who is diagnosed with straightforward type 2 diabetes mellitus. Page 83 is metabolic syndrome. I love metabolic syndrome. I think it's a great diagnosis, not to have it, but it's a great diagnosis because it's a great way to talk to your patients about healthy activity and healthy ways to help their body from not ending up with scary things like renal disease and cardiovascular disease and strokes and heart attacks. So it's a great way to talk about it because it doesn't talk about weight. We have too much focus on obesity and weight being the conversation that we have with our patients, and it just offends them and upsets them, and they're not listening to you. They think you're just another one of those doctors that thinks everybody has to be skinny, and a lot of people aren't. So we have to talk about other things, and that's being healthy. So metabolic syndrome has 5 criteria. You need 3 out of the 5, that's the belt buckle there, to make the diagnosis. Now, the first one is elevated waist circumference. I remember 35 inches because it's just something I like to remember for myself, being less than. Now, 88 looks like 2 people standing together. And if you need a belt for 2 people, for 1 person, that's pretty high. So 88 centimeters is an elevated waist circumference. This is not neck circumference. That's sleep apnea. Elevated waist circumference is metabolic syndrome. Number 2 is elevated triglycerides, greater than or equal to 150. 3 is reduced HDL, less than 50. Remember, HDL is the good one. You want to hold on to it, hug it, hold it. And that's going to be higher, the better. But this is less than 50, which is bad. 4 is elevated blood pressure, and it's the weird blood pressure. We don't use this number for anything else. So I just remember it goes along with metabolic syndrome. 5 is elevating fasting glucose, and it's greater than or equal to 100. Now I'm going to tell you a couple of ways to remember some things about metabolic syndrome. The numbers are 50, 100, and 150. So if you can remember those 3 numbers, they make sense where they go. The HDL is definitely less than 50. The glucose, goes in a range around 100. And elevated triglycerides is 150. Now, if you have trouble remembering which kind of glucose test this is, because technically it has to be this glucose test to qualify, it's elevated fasting glucose, because you're going to encourage them to exercise for their health, and you're going to want them to run fast. All right, here's our creepy little sperm guy trying to get a date with these eggs here, and they're just telling you some information about sperm analysis. Sperm analysis goes back and forth on what things are most important. But I'll tell you, morphology is one of the highest considered important factors when it comes to reproductive endocrinology and infertility. That takes us to urinary system and incontinence. Remember, I hated everything to do with urinary system. So I came up with great ways to remember everything, and I'm going to help you through those now. Bladder function and medications is super important. If I can get you to understand this, you're going to understand about 97% of what you need to know about bladder function and medications. So let's take a look at what we have here. First of all, the detrusor is a muscle, and it stretches and stretches and stretches. That stretching has stretch receptors, and at some point they say, that's enough stretching. And they send a message to the pons, which kind of goes with pee-pee, right? It's time to pee. So it sends a message to the pons to start that activity. And then it also sends a message to the micturition center, which is at S2, S3 spinal cord level. The micturition center reacts to parasympathetic and sympathetic pull and push. If it's going to be someone who's micturating or urinating, that's going to be parasympathetic going up. If it's going to be somebody who's not, that's going to be sympathetic going up. But in this case, we're trying to urinate, so it's parasympathetic going up and sympathetic going down. Once the micturition center is activated and the parasympathetic response goes up, that person can go ahead and urinate. Now, the detrusor muscle has some receptors on it that we have to know because they're really, really important. Now, you might see this other one down here with the internal sphincter. Leave it alone. Don't touch it. Don't mess with it. That one needs to do what it needs to do. But we're going to go ahead and work with the beta 2 and 3 and the M3 receptor that are up top. Beta 2 and 3 is going to remind us that beta is a stopping receptor. I bet I can make you stop. That's going to be beta 2 and 3. We're mostly dealing with beta 3, but bet I can make you stop. That detrusor muscle from squeezing is beta 3. Now, mirabegron is our first medication we're going to talk about. Mirabegron is a beta 3 agonist, so it's going to make those beta receptors go more. So beta 2 and 3 are going to stop the detrusor from squeezing, bet I can make you stop. And then remember, mirabegron, look, I'm begging you to make that detrusor stop, and that's the beta 2 and 3. So it's got all the parts in there to remind you of what mirabegron does. That's for urge and overactive bladder. Now let's move on to M3, which is muscarinic receptors, and that works with 2 different medications, botanicol and oxybutynin. So let's talk through those. The M3 receptor is a go receptor, so it's going to make the detrusor muscle squeeze. So make the muscle move, M3, make the muscle move. When it comes to those M3 medications, let's start with our muscarinic 3 antagonist, and that's going to be still for urge and overactive bladder, and that's going to be oxybutynin and tolterodone. So I like to think of an ox standing in the middle of the road and just not wanting to move. So it's stubborn and it's not going to like M3 make that muscle move. It's going to stop it from doing that. Tolterodone is I told you to stop it. I told you to stop it. Muscarinic 3 receptor. Don't make that muscle move. I told you to not make that muscle move. Now, let's move on to another pathology, which is urinary retention. Urinary retention works with a muscarinic agonist. That's botanicol. Botanicol is an agonist for that M3. So it's saying, bet, make that muscle move. Bet, make that muscle move. Botanicol, muscarinic 3, make that muscle move. If you can remember these and you can lock them into your memory, you need to know you have just about everything you know, about 92%. Now, if you want to get up to that 97%, you're going to do some homework. And that 97% is contraindications for these medications. And then also the side effects that they occur. See, not that bad. We can learn these things. We can make them easy. Incontinence. So first and foremost with incontinence, when you're talking about it, there's actually those things with incontinence present and those things that do not have incontinence present. The only one that cannot have incontinence present as one of its presentations is overactive bladder. Overactive bladder is the involuntary spasmodic contractions of the bladder. It's often associated with complaints of nocturia and urge. May or may not have incontinence or urge present. Nocturia is a big keyword for overactive bladder, so make sure you point that out to yourself. If a person gets up 3 or more times in the night to go pee, that's nocturia. That's abnormal. They should have things checked out. Now, treatment for this, and one of the most important, is bladder triggers. Realize that all of these different things can be bladder triggers and can be modified to help with overactive bladder. Now, moving up from there, we have urge incontinence. Urge incontinence has incontinence present. This is complaint of involuntary leakage of urine with urgency. So like they all of a sudden say, oh, gotta go, and we're peeing. Don't get the chance to do anything about it. This can be things that are treated by botulinum injection, pelvic PT, those post-tibial nerve stimulation units, or cytoplasties. Now, moving farther up in the incontinence, we're going to be looking at mixed. Mixed is when you have overactive components and you have stress incontinence components, and that's mixed. Most of the treatments for stress and urge will apply with proper evaluation, and they'll work for mixed forms. So you got urge components, you got stress components, and you got overactive components. They're all blended together there in the mixed. Let's move up to stress incontinence. It's the most common one at 41%. This is complaints of involuntary leakage of urine with exertion or valsalva. So this is laughing, sneezing, coughing, or the one you always hear, which is somebody jumping on a trampoline. And you're like, why is that an example? Well, literally, I had someone come in and she said I was at my granddaughter's birthday party jumping on their trampoline in the backyard, and I literally peed my pants. And I'm very upset about it. What am I going to do? This is going to be stress incontinence. So it does happen, the trampoline thing. Treatment for this can be things like Kegels, pessary, artificial sphincters, periurethral bulking, and pelvic PT and slings. So make sure you understand that incontinence does not always mean there's incontinence present, and there's multiple types. There's 3 reasons for stress incontinence, the main reasons. That's going to be loss of intra-abdominal urethra. So there's a small portion of the urethra that's inside the abdomen, and it's there for a reason. If you cough or sneeze or apply that Valsalva, there's pressure all over the top of the detrusor in the bladder, which is going to push that urine out. But if some of that pressure goes to the urethra and it also gets that shock to push itself inward and take that pressure, it's going to pinch off and keep that urine from going outward. However, if there's no portion inside the abdominal cavity, that pressure that comes is going to directly push that urine right out. 2 is the hypermobile urethra. The urethra is meant and designed to be in a straight line sitting there and then at a special angle connected to the bladder. It's in its own natural muscular and fascial hammock. It's designed to be held there in a very specific position. If those things start to relax or damage, then it's going to become hypermobile. If it's hypermobile, it's moving and pulling and taking away that rigid structure and that angle that keeps the urine in. Loss of angle is the 3rd one. Now, it's not this dramatic, but that's just to show you that there is an angle there between the bladder and the urethra that keeps the urine in place. Here's a little bit of other info. All we're going to show you here is Professor Research. Professor Research was a good friend of mine, and this was a doc that always carried around his case series and case reports, talked with the residents as well. Let's do research on that. Let's look at this. These are parts of observational studies. So he's walking around looking at all these things he could do. Descriptive studies are the weakest form of studies, and they're things that you just carry around with you until you actually turn them into good, solid studies. So there's descriptive, and then there's analytic. Analytic is things like cohorts, a way to look forward, like horses running forward on a racetrack. So cohort is looking forward. Case control, or the initial CC, is like a credit card. You get your credit card bill, it's showing you what you spent in the past, so it's looking back. Cross-sectional is one point in time. That's all you're looking at is right then, right there, and nothing else. Now, on the experimental side of the table, you have the best possible study, which is a randomized controlled trial. There's also non-randomized, which isn't as good, but randomized controlled trials are the best. All right. I hope you enjoyed the OB-GYN Illustrated. I hope it gives you some of those great things to think about so that you can go ahead and pass those questions on an examination and call me back to tell me, yep, I remembered something from the book. Thank you so much. Don't have to, but I enjoy it. So thanks for taking a look at my notes with me and learning along with me.